All right. Well, welcome back to BPH The Breakdown. This Thursday, every Thursday at 6:45 Mountain Time here in the United States. I think it's 1:45 GMT. So thanks for everyone being here. We're going to be talking a little bit about the importance of using tools to help us understand how to predict the risk that comes with the polypharmacy epidemic. So let's talk a little bit more now. So we're going to touch upon the COMBAT study, a really pivotal study for all of us in the BPH BPO world, as well as bphtool.com. And let's take a look at it now a little bit closer. We're really talking about the polypharmacy epidemic as we all remind ourselves as defenders of the detrusor of the 3 Ps. That's right. We are prioritizing the preservation of bladder health. We are preventing late-stage BPH, BPO, and we are, together, putting an end to the polypharmacy epidemic. And there's multiple definitions of polypharmacy. For us, the simplest one is always going to be medications. The number of medications you can see here on this slide at the top defined as 2 or more medications for more than 240 days, so long-term medication use. But also in definition of polypharmacy is a descriptive term of being the simultaneous and long-term use of different drugs by the same individual, or potentially using inappropriate medications. And I would make a case that long-term medication use for BPH BPO is an inappropriate use of medications because medications are not a therapy for a mechanical problem of BPO. They are a temporizing measure that allow us to buy time to do the proper assessment with a bladder health baseline so we can decide if surgery, when warranted, can be performed for the right patient for the right prostate at the right time within the window of curability. And so with that thought, once again, we remind ourselves from Defender Amanda Chung from Australia about why we do what we do, and it's to protect the bladder from death, destruction, and dysfunction. And we can see here on electron microscopy by her valuable work, as well as wonderful cystoscopic images from Neotrax showing trabeculation, cellules, diverticuli as the cystoscopic findings. Don't forget, once again, trust the truth of trabeculations on your cystoscopy. That is a detrusor under duress, as Defender Sunny Shellen reminds us. And we do this as we fight together on the battlefield against the 4 horsemen of late-stage BPH BPO. On the far left, detrusor overactivity, then urge incontinence, then acute retention, and the worst, detrusor underactivity, putting the bladder at risk of failure. And to have created the triangle of triage, which continues to evolve, understanding who is at risk when they come in, and folks with an IPSS greater than or equal to 8, plus a Qmax less than 15 and or a PVR greater than 100, as well as those reporting history of urge incontinence or spontaneous retention, need a bladder health baseline at a minimum involving cystoscopy with enhanced or advanced urodynamics when available. And we will talk about how Man vs. Prostate soon is trying to break down urodynamics into various levels of technology and sophistication, from basic to enhanced to advanced levels of urodynamics, which is really important as we move away from the terminology of invasive versus non-invasive. I think it's too crude, and linguistic determination shapes how we think, how we act, and how we create our habits. And when we use the term invasive, that's actually counterproductive in helping our patients find the best solution for their BPH, BPO. So let's dive into the COMBAT trial, a pinnacle study, 2010, multi-center, randomized, double-blind, and it's just part of a long lineage on the right-hand side of our exploration into medications. Remember, as Defender Austin Slade reminds us, medications came out of a time when we had very few surgical options. We had either TURP, or we had open, simple prostatectomy. And the morbidity and mortality of those procedures were very high back then. And so we created artificially the sense that medications were a therapy when in truth they are just temporizing measures. And we chose to create this category of therapy with medications because we felt it had a more favorable benefit to risk profile as compared to TURP and open simple prostatectomy. And at that time it did, but we kind of lulled ourselves into falsely thinking that it was a true therapy for obstruction. But at the end of the day, chemicals do not deobstruct. And so as we move on, the demographics of the COMBAT trial, unlike the MTOP study on the right-hand side, the COMBAT trial looked at dutasteride 0.5 milligrams monotherapy, tamsulosin 0.4 milligrams monotherapy, as well as combination therapy, dutasteride and tamsulosin, looking at almost 5,000 patients internationally, men who were 50 and older by age, a prostate volume of 30 or greater, PSA between 1.5 and 10, IPSS 12 or greater, looking at primary endpoints at 2 years, which was an improvement in IPSS, and at 4 years, looking at the reduction in risk of retention or surgery. And they were pleasantly pleased to see that there was a decrease in IPSS, with the greatest decrease seen for combination therapy. And I think it lulled us into the sense that, hey, we're doing something positive. But in truth, from the man versus prostate perspective, globally, as we unite as defenders of the detrusor, we recognize that actually it was just masking or obscuring the fact that these bladders were still continuing to struggle under the vice and the tightening grip of the evil prostates as they continue to grow and narrow the prostatic channel. As you can see on this graph here, or this table, follow up at 4 years, that even with combination therapy, we were seeing clinical progression at 13% in that group. That is too high, and that's only at 4 years out. If you look and drill down a little bit more, we see that the percent of folks who had an increase in their IPSS by 4 or more points, so this would often be indicative of stage 2 detrusor overactivity getting worse, that was 9%, almost 10%. For those folks who are entering into stage 3 urge incontinence, we saw a rate of 3%. And for acute retention, which is stage 4, we were seeing a percentage of 1.6%. Once again, these are all numbers at just 4 years. And while we could pat ourselves on the back that, hey, with combination therapy, there's a 66% risk reduction for having an episode of retention or needing surgery, as compared to tamsulosin monotherapy. The truth is, any drug therapy, combination or monotherapy, puts those bladders at risk for late-stage BPH, BPO, or the need for eventual surgery. And we can see it on this graph. All I did is I took that first graph and I extended out the timeline just to allow us to kind of get a glimpse into what might it look like. What is the risk potentially when we proceed out to 8 years, as you can see on the bottom x-axis, and maybe even out to 10 years. And I would say that look at the consequences with dutasteride monotherapy or combination therapy at 10 years, potentially the risk for retention or need for BPH surgeries at around 13 or greater percent. And if we look at tamsulosin monotherapy, that risk at even higher than 30%. And we are not willing, as defenders of the detrusor, to allow our patients to suffer needlessly when we can do more, especially in this time of the golden age of BPH, BPO, with so many different types of surgical deobstructive technologies, from LIST to MIST to IST and to MOST. We have so much at our fingertips that together we can unite, deobstruct these prostates for the right patient with the right technology for the right urologist at the right time within the window of curability. Big shout out to Wilton Rogers. Thank you so much. Hey, it's great. Thank you for inspiring. If you guys don't know, check out Wilton Rogers, looking at robotic automation, changing the way businesses operate more efficiently, more effectively. Just a great guy. If you guys ever get a chance to meet him, he's got a magnetic personality and a smile that can light up a room. So great to see you, Wilton. Thanks for jumping on. Hey, and if you have any tips or tricks, because I'm still brand new to this and you're way farther along, please let me know. So with the combat trial, we talked about it, that these are unacceptable risks that we are putting our patients at. So let's take a look now at this great tool that's out there. And it is from bphtool.com, and it was put together by GSK, a pharmaceutical company, GSK Statistics and Data Science Innovation Hub. And what they did is they did a great job of looking over 9,000 patient lives through the combat trial, as well as dutasteride versus placebo trials, the Area 3001, Area 3002, Arab 3003. And we shout out to Defender Stavros Gravas for his great work putting this model together for all of us to benefit from. And what it does, it allows us to enter in for each individual BPH, BPO patient. On this far left-hand side, their IPSS or symptom score, prostate volume, post-void residual, maximum flow rate, PSA, as well as whether or not they used an alpha blocker within the last year. And this is what it kind of looks like. It's able to give us a sense of how much improvement can be expected looking at IPSS, as well as how much risk is there that they might have an episode of retention or need surgery down the road. And what's great about it is now you can really dial in and get a sense for your own practice or the types of patients that you see to get a sense of how at risk are they, or you could even do this with your patients. And so this is just an index patient I came up with, 65-year-old, IPSS of 16, PSA 2.5, PVR 50, with a maximum flow rate of 14 in the equivocal range between 10 and 14. And we can see here on tamsulosin monotherapy, yeah, those bladders are at risk for having retention. We can see it at a 30-gram prostate, about 6%, rising to 7% for a 50-gram prostate, up to about 10% for an 80-gram prostate, up to a whopping 20% for a 150-gram prostate. But then you can modify it. So if let's say we change the maximum flow rate down to 9, those risks for entering into retention or needing surgery with tamsulosin monotherapy now begins to really rise. We can see that now at 50 grams, it's 10% risk, 80 grams, 14% risk, as well as 150 grams at a whopping 27% risk. These are risks we are not willing to take unless needed to for medical reasons. But yes, let's take a look here. I think let's go live here to the actual website. So bphtool.com/bphtool. And you can see that at GSK. So let's kind of hit return here. All right, so you'll see when you load this up, it'll say for English. That would be me. My Spanish and Portuguese is definitely not good enough for this. Perfect. And it'll just ask if you're a medical professional. Make sure we regard this. There's a liability thing. This is for healthcare professionals only. So I am a medical professional. There's disclaimer, some information. I agree. And what's great now, you can see on the left, there's a whole panel where we begin to enter in data for our patients. The most basic place to go to is the total IPSS acute retention surgery tab. So we click here at the top. Great. And so what we're seeing here is on the left, we can now begin to enter in age, IPSS, prostate volume, PVR, maximum flow rate, and PSA, as well as whether or not they've been on an alpha blocker within the last 12 months. And so what's great about this now, we can enter things in. So like I said, hey, let's go with a 66-year-old, even a 70-year-old, 71-year-old there. IPS, let's just make it something moderate, 17. Prostate volume, 55, sure, that works. PVR, 60, great. Let's make it even 80. Q max would be 11, that works for us, and a PSA of 3.5. And you can see in real time, it's beginning to modify and update the risk. So here on the left, we can see that this is what we can expect for a decrease in monotherapy. And we can actually hover over the curves and begin to see how much improvement. So we can see here at about 12 months, placebo would have an improvement of 2.5 points, dutasteride 4.7 points, tamsulosin 5.2, and combination therapy of 6 points. But more importantly to us as defenders of the detrusor, as we begin to assess risk for late-stage BPH, BPO, we can now do the same thing. And you can see here out to 4 years. Let me get rid of this here. This is in the way. You can see that risk is 10% at 4 years already for this gentleman about having to enter in retention, showing up in an emergency room because he can't pee at all and needing a catheter. And we can see those risks as they here. But regardless of whether it's monotherapy or combination therapy, these men are at risk for late-stage BPH, BPO, and we need to get those bladder health baselines and assessments to help them understand their risk and determine whether or not surgery may be indicated when warranted once we factor in all those parameters, prostate size, prostate shape, as well as detrusor function. And we need to let the bladder give voice to surgical choice. And that's very important for all of us to really recognize in this day and age, this golden age of BPH, BPO care, where we prioritize the preservation of bladder health. I mean, that's why we, look at this new t-shirt we just came out. Hey, what about my bladder? That's right. And we want all of our patients coming to all of us urologists with that focus so that we can help them get a bladder health baseline. So yes, we can find the right technology for the right prostate, for the right patient at the right time within the window of curability, because we do want all of our patients living the best version of their lives, chemical-free and catheter-free. And so with that said, we'll finish up the slide deck here. As always, the man versus prostate mind mapping continues to evolve as we begin to shape the BPH, BPO care pathway together across the globe. And it's going to look probably something a little bit like this, not to freak people out. But yes, that's why we've been building over the last year or two now all these instrumental parts of counseling, screening, and triage for identifying bladders at risk so we can risk stratify with bladder health baselines, which is the second column. And then with the third column in the middle, recognizing that it is a shared decision-making process 3.0, where there are 4 parties that come to the table, not just the patient and the provider, but also the healthcare system and, of course, the bladder. But that allows us, if we allow the bladder to give voice to surgical choice, we can now create multimodality treatment plans, especially for overactive bladder, because often we do intervene too late, and we need to be able to add additional either at the same time of deobstruction or at a staged later point. Because at the end of the day, we need to integrate all these wonderful facets that we now have in this golden age of BPH, BPO. And finally, yes, we are finally going to try and get the Man vs. Prostate Manifesto out sometime this year, if possible. And that would be great. Thank you for all your support as we continue to refine it. And as always, ending with a wellness quote, in order to achieve the impossible, one must first try the absurd, from the famous Portuguese poet Fernando Pessoa. And so as always, thank you guys for being defenders of the detrusor wherever you are, inhabiting and transforming the space that you live in, that your sphere of influence, so that we together can go save more bladders. All right, thank you guys so much. It's been great, as always, being with you all. And together we can go save more bladders. All right, have a great one. We'll see you at the next one. Take care now. Bye.